All right. So CTO complications. Certainly, CTOs, as all we know, are more complex procedures, and there are more complications, therefore, so you got to be aware, as well as the patient has to be aware, because most of these patients, they are coming for angina, so you do not want to treat angina and leave a patient with a major complication. So we divide it in non-cardiac and cardiac. I think the important things are you need to have the procedure within safety measurements, so you need to limit your radiation exposure, try to use 7.5 frames per second fluoroscopy, limit the number of cine runs, rotate the image intensifier every so often, because that will prevent skin lesions, and have a planned radiation limit, whether it's 3 grays, whether 5 grays, somewhere around supposed to be your radiation limit. So the other one is, as we see in the previous talk, you can do it with limited contrast, so limit the number of injections, use diluted contrast, microcatheter injection, and use anatomical landmarks and coronary calcification to guide your procedure. So vascular complications is another thing that you will encounter. You remember that you will have double injections, and you might use a French guiding catheters. So something to take in consideration, use ultrasound-guided access with a micropuncture device, and with that you will prevent complications. Appropriate anticoagulation is important, and according to the case, radial access may be your donor artery access. So cardiac complications, and here is where we have the most. So we can have what is donor vessel complications, and here you can have the donor vessel can be a very important source of collaterals, and therefore you got to pay attention, because if you are damp or you are not paying attention, the guiding catheter gets too deep in it, it will produce ischemia, so pay attention to that. It can have complications like donor vessel occlusion, dissection, or thrombosis, so again, you got to pay attention. And one thing is very important is to look always at your blood pressure in the donor vessel. If you notice that there is something wrong with the blood pressure, you pay attention to that, okay? So the last one is, because you are in the osteonoductal artery for quite some time and you may not be paying attention, this guiding catheter can damage the osteon and produce an aortic dissection, mainly when you inject. So these are the complications, how you prevent it. Early detection is very important. May need to do a PCI first, disengage the guiding catheter and get a wire in order to maintain stabilization, appropriate anticoagulation to prevent thrombosis, open the Y connector and back bleeding if you notice some problems, and use a support device like a guide extension in order to prevent the guiding catheter to go back in and out and damage the proximal vessel. The CTO vessel complications are a kind of similar kind of problems: proximal dissection, vessel thrombosis, and ascending aorta dissection. Anchor technique and guiding extension may help to prevent this excessive guiding catheter manipulation. And again, appropriate anticoagulation, as Dr. Kim showed you, this is very important. Again, open the Y connector. So ascending aorta dissection is not uncommon. It is much higher, the incidence in CTO intervention than in regular intervention, and it's somewhere between 1 to 2%. Main is more common in the right coronary artery. Usually is produced by the guided catheter manipulation. Usually it's an Amplatz catheter. We deep seat these catheters many times, and then can be produced that ostial PCI as well, or can be produced by subintimal tract of the retrograde wire, so you got to pay attention to that as well. So how to prevent this? Avoid excessive guiding catheter manipulation, use techniques like guiding extension or anchor technique, avoid power injection. I do not know if it's popular here in the United States. It's popular to use the power injection. I do not think that should be used in CTOs. Guiding with side holes, in my opinion, is questionable, but some people like to use that. Look at the blood pressure waveform. Very simple thing. Look at if it's damping, it is a problem. Do not inject. Avoid propagation of the dissection. If you think that there is a dissection, do not inject, as well as inject distally using a microcatheter. So how do we treat this patient? The vast majority, you can treat it with a stent at the ostium of the coronary artery, and the vast majority will respond to that. Make sure that you have at least 1 millimeter of the stent hanging into the aorta. You can use IVUS to guide other techniques to make sure that you are covering the ostium. If the extension is more significant, also the vast majority will seal on their own. So you follow this patient either with CT or TEE, and if there is no propagation and stability, just you leave it and they will resolve on their own. In just very unusual, you will need bypass, you will need surgery if there are signs of tamponade, meaning that the dissection progress into the heart pericardial space, or there is aortic regurgitation. Otherwise, in general, I will be more conservative, and most of these patients will heal. Side branch occlusion is another complication that you can have, and you can have this because you went subintimal, and then you came back into the true lumen at the side of the side branch, and then when you put a stent, you will occlude the side branch. It can occlude due to vessel thrombosis, or it can produce, again, dissection of the aorta. So important to recognize and try not to put a stent if that happens, because you are going to lose the side branch. Sometimes it's better just to leave a dissection and let it heal the dissection, and we call that an investment procedure. So just leave it on, heal, and you bring the patient in 6 to 8 weeks again to complete the CTO, to do the CTO and put the stent. The vast majority of the patient will remain with the artery open, like we've seen in the case a few talks before, and if not, will be easy to recross. The other one is where we talk about collateral occlusion already. We didn't talk about the collateral occlusion, I'm sorry. So this is more frequent when you do epicardia than when you do septal. But remember that when you start to use the collateral, you can lose these collaterals that were present, and then your patient will be ischemic. So it will take some time for them to improve, but if the patient has some source of left ventricular dysfunction, you can get into a hemodynamic trouble there. So be aware of that, and you may need to resolve this with additional treatment. So subintimal stenting, that's another thing that it is important. So it's very important to know and recognize that the wire is in the true lumen. And many times we do believe that the wire is free, and we manipulate the wire and it's free, and you think that you are in the true lumen. That is not appropriate. You need to confirm by a dual injection that you are in the true lumen. And remember that many times when you think that you have collateral from the main artery, when you pass the microcatheter and when you pass the wire, you will lose those collaterals. So you do need to put another catheter to inject from the other side. And even if there was no collateral from the other side, you will see that those collaterals will appear when you close the main vessel. So what happens is you go into the subintimal, and you may go into the true lumen, and then you go back into the subintimal, and then if there was a side branch, you will occlude this side branch. Or if you did not confirm that you were in the true lumen, you thought that you were in the true lumen and you stented, and when you stent, you stent subintimal and you collapse the distal lumen of the vessel, and it's very challenging to resolve that. So another problem is vessel thrombosis or embolization. And remember, these are prolonged procedures with a lot of hardware, so you may have these type of problems. So thrombus aspiration might be needed, but you can embolize plaque, so this has to be taken in consideration. And another important thing that you can embolize is air. So remember that you have a lot of tools in there, and when you try to remove a balloon, many times what you do is you are sucking air by a Venturi effect, and if you did not open your TUI board to allow this blood to come back, you are going to infuse air. Certainly the treatment for that is try to do air aspiration and oxygen. So as you can see here, this is a retrograde case, and you have a guiding catheter, extender catheter, Godzilla, whatever you use here. You have a wire, you have a microcatheter, you got a previous stent in this artery, and in this side you have similar things, guiding catheter, guiding extender, microcatheter, and a wire, And then when you go forward, you have in addition a balloon and another wire going backward. All these things are procoagulant things, so make sure that you have the appropriate anticoagulation. The last one, but probably the most risky of all, and the one we are more concerned, is coronary perforation. And the coronary perforation can be in the main vessel, in the distal small branch, or in the collateral branch. So this is a case of perforation in the main vessel. I didn't show the case, but because it doesn't matter, but you see a very open perforation here. So the first thing that you do is you put a balloon in there to tamponate. The second one is you get access in the other artery, in another vessel. So because this perforation is very large, because the perforation is very large, if you need to remove this balloon and put the cover stent, you are going to be exposed to a tremendous amount of additional bleeding. So you get another access, you get another guiding catheter, and then with the other guiding catheter, you do a switch of the balloon. So you remove your balloon and you put the cover stent. In this case, the patient was having a significant hemodynamic involvement, so we need to do a pericardiocentesis, and then we put the cover stent. So it looks like this is it, but it is not. Sometimes the cover stent does not work, and you see after we put the cover stent, there was still a very sizable perforation. So there are different things that you can do here. You can do a larger balloon and expand the cover stent more. Some people are concerned about larger perforation. It's unlikely because you have the cover stent. Sometimes the cover stent will not expand in the edges, so you may put a non-compliance balloon to expand this stent. If it doesn't work, so what I did in this case, I put a second stent, but not a cover one. So most of the time what happens is the stent the cover stent doesn't expand well on the edges. So what I did is I put a regular stent, but a larger one inside the stent. And with that, we have a complete resolution of the perforation. So another perforation that you can have is a perforation in the distal vessel. So this is a simple intervention on it was not a CTO, but it doesn't matter, that makes the point. It's a simple intervention here, and we have the wire here. But if you look at here, you do the balloon, and you don't see the wire any longer. So the interventionist thought that everything was wonderful. We go home, and he takes the last picture, and you see that there is a distal perforation through a wire that was all the way here, and in this tiny branch, it goes a very significant perforation. Again, what do? We put a balloon in order to control this, and the next step on doing this is to put a coil. The distal perforation, you cannot put a cover stent because there is no way to put a cover stent, and you do not want to occlude this vessel. So you coil the artery, whether with a coil or whether with fat or whether with thrombus that you can create with thrombin. So you put a microcatheter as distal as possible, and you deliver the coils, and then the perforation is resolved. Okay, we have two coils in here, and you see there is no more perforation. So you got to be familiar with this. The last one is collateral branch perforation, and if there is a septal, in general, the septal will not be a problem. You just leave the microcatheter there for a little bit, and it will seal the perforation. If there is a septal hematoma, usually it's not a problem. It will limit itself. If it's the epicardial, it's a little more of the challenge. There are different things that you can do. You remember the epicardial, they will receive from both arteries circulation. You will need to be aware of that, and you will need to coil from both sides, or you can use a microcatheter from both sides by putting it in there and aspirating. Sometimes it produces sucking of the collateral, and the collateral will close, and as you just leave it like this for a few minutes, and it will close. So, summary: balloon tamponade, cover stent, coilings, autologous fat or thrombus. If hemodynamic compromise, pericardiocentesis, consider reverse anticoagulation, and if nothing works, you might need to do balloon occlusion and call CT surgery, and if there is hemodynamic instability, you might need to put a left ventricular assist device. So to conclude, complications are more frequent in CTO interventions. Good understanding of the case prior to the PCI is critical. Key safety measurements are important. Good anticoagulation. Look always at both system pressure waveforms and be aware of possible embolization and air suction. Have a plan for potential complications. The staff is an important part of the team. They should prepare to assist in complications. Coronary perforation will occur. It's not a problem. It is will occur. The entire team should be involved in the solution during dedicated training, and mock cases usually help for the real case, and be familiar and have access to dedicated equipment and devices to resolve perforations. Thank you.